And thank you for the organizers again for asking me to come and speak on my favorite subject, diabetic neuropathy. So, actually I should, again, remember the FIFA World Cup. I left that to come here. Inshallah, I'm going back tomorrow. So these are my disclosures. And we start with diabetic neuropathy. So diabetic neuropathy at a basic level is damage to the nerves and damage to the large fibers, which a lot of people focus on actually. So what's happened? Technology. Just this one. Okay. What about this one? This one works? Okay. All right. Okay, so the large fibers and to the small fibers. And actually, this is convenient because the large fiber animation didn't work, and the important message is large fibers are a waste of time examining for them. It's the small fibers we should focus on. And why? Because small fibers are the fibers that are damaged for pain, but also they are key to the development of foot ulceration, because if you get damage to the small fibers, particularly the autonomic nerve fibers, then unfortunately you develop a foot ulcer, and this is the consequence. So this is for my vascular surgical colleagues over there, just to show you that this is something you're doing now, but you were doing 100 years ago. Very well. Very efficient, very efficient. Okay, so back to the Cinderella complication. Why is diabetic neuropathy a Cinderella complication? Well, for many reasons, but one of the reasons I think is neuropathy has very poor tests that we use in clinical practice. If we look at diabetic retinopathy, we have digital retinal fundus photography, we have OCT. For nephropathy, we have microalbuminuria, we have EGFR. For neuropathy, unfortunately, we rely heavily on clinical examination, monofilament examination, which I think is okay for screening for high-risk diabetic foot, but is not good for identifying early neuropathy. And so therefore, late diagnosis, patients suffer, there are failed clinical trials, and there is no current FDA-approved treatment. If you look at diabetic neuropathy, painful neuropathy, there is this rough figure of 1 in 5 individuals have painful neuropathy in the rest of the world. When I came to this part of the world, we decided to do a study where we looked at hold it. Okay, right. So we did a study where the standard was 21%. But we did a study in the Gulf region, 3,000 patients in Qatar, in Saudi Arabia, in Kuwait. And we applied a simple questionnaire and assessed vibration perception. And what we showed actually is that the prevalence of painful diabetic neuropathy, and painful diabetic neuropathy particularly, was much higher. It was 43%. 1 in 2 individuals almost had painful neuropathy in this part of the world compared to 21% in Europe. Now, why might that be? Well, it might be because there is actually obesity is a major driver of small fiber damage and pain. But the major other finding was that about half of these people previously had not been diagnosed or treated. So we are missing a lot of painful neuropathy. The other issue that I want to highlight is problem of late diagnosis. So I talked about large fibers and all the tests that we use. You can see at the bottom, monofilament, vibration perception, nerve conduction. What do they measure? they measure the large fibers. Large fibers constitute only 5% of the total fiber population, and they are the last to be damaged. What you actually are missing is the small fiber damage, which is occurring early, even in pre-diabetes, and I'll show you data, but also it is occurring at in pre-diabetes. So really, this is the opportunity that we have, and we are missing this. So how do we change this? Well, I hope this video works. Audio. So this is a famous scene from Gladiator. And the only reason I put this up is because Marcus Aurelius is the famous emperor who oversaw. It is dramatic when you have the noise, the voice, the sound in the background, but what you'll see is Marcus Aurelius there, depicted by Harris, and he's saying, if you listen very, very quietly, I know the audio isn't on, but what he's saying is the following. We need to learn to measure what we value, not value what we can easily measure. And so for diabetic neuropathy, I think whilst we easily can measure monofilament, we can easily measure vibration perception. Okay. This is uplifting music, but you get the message. So we need to measure what we value. And for me, it has to be the small fibers. And we're missing out when we're not measuring the small fibers. Okay, so we need to open our minds and have the courage to throw out yesterday's ideas when they don't appear to be working. Unfortunately, in medicine, we find this very difficult. We are stuck on old ideas and we think that is the absolute truth. And unfortunately, we don't make progress. So I'm going to be brave and challenge what we have. And I would say, you know what? If these aren't working, we should do away with these. So what could be an alternative? Well, here's an alternative. This is a completely stupid idea, especially for the young people in this audience. If you have a good idea and it's a stupid idea, keep with it, okay? Because when I was a junior, I had this idea. And everybody, when I talked about it, people thought, this guy's crazy, right? He doesn't understand neuropathy. So this is something called corneal confocal microscopy, which is an ophthalmic instrument which measures small nerve fibers in the cornea, in the eye. Okay, and it's a very simple, easy technique. Whereas if I wanted to measure small fibers in the skin, I have to do a biopsy, I have to send it to the lab. It's really not very easy. And what you can see here are lines, and what you have is a window, an opportunity to be able to, to look into the eye and measure nerve fibers. And you might say, well, that's a crazy idea. Well, it was until we looked at patients with diabetic neuropathy. We measured them according to nerve conductions, monofilament, everything, and you staged the neuropathy severity. You can see from mild, moderate, severe. We then measured the nerves in their eyes. And what you see is that in the first panel, the white lines are the nerves. And you can see in the patient with severe diabetic neuropathy, there are very few nerves, and there's a progressive dropout of these nerve fibers. So we have a beautiful way of measuring nerves in the eye that reflects what's going on in the rest of the body. And that was with 18 patients. We then actually went on and we took on this work. I hope it works. And I'm not Captain America. Avengers! Assemble. So that's the good guys, that's me, and all my team. And then there's the bad guys who are, unfortunately I hope there's no neurologists in here. But neurologists and cardiologists, as Ralph will tell you, have this thing that they think endocrinologists are stupid, right? You know, we aren't good enough, right? We're like failed medics, right? But actually, alhamdulillah, we've shown them now things, that the things that they never thought of. So, for painful diabetic neuropathy, simple message. If you believe that pain is from the small fibers, you would expect less nerve fibers or more damage in those with pain compared to those without pain. And that's exactly what we've done. We've actually looked and we've shown that if you have painful diabetic neuropathy, corneal nerves, there are less nerves compared to painless diabetic neuropathy compared to healthy controls. Moreover, we've shown that the severity of pain, the more severe the pain, the less the nerve fibers. So there is a relationship between the nerves in the eye and the pain that patients perceive. The other thing that we've done is looked at people with pre-diabetes, impaired glucose tolerance. And what we show actually is that already in impaired glucose tolerance, there is already a loss of small fibers in the skin, but also small fibers in the cornea. You can see on this panel in the IGT group, about 40% have more than a 2SD loss. And then I gave this talk before in Turkey, and I remember Mohammed coming up to me and saying, but what happens to people with IGT? Can you use this as a marker in terms of progression or regression? Because as you know, people with IGT, they can remain IGT, they can go to become normal glucose tolerance, or they become diabetic. So actually, we've looked at this in two ways. So we took a cohort of people with impaired glucose tolerance, 30, and we followed them over 3 years. 17% went into normal glucose tolerance, 50% remained IGT, 33% developed type 2 diabetes. What was in their corneal nerves? Well, we looked at their corneal nerves, and what we showed is that if you had normal glucose tolerance, you had more nerves to start with compared to impaired glucose tolerance compared to type 2 diabetes. You can see that the people who developed type 2 diabetes actually had less nerves to start with, but also they lost more nerves. So in a way, I could measure the corneal nerves now in a patient with impaired glucose tolerance, and I could predict that person who will go into type 2 diabetes as opposed to that one that won't. And in fact, if you look at the corneal nerve fiber length, those that were more than 2 SD lower than controls, 100% of those developed type 2 diabetes. So that's the predictive value. And not just for those who developed type 2 diabetes, but also we've now looked at people who have no neuropathy right now, but we've followed them over 2 years to see if they can predict those who develop neuropathy. And again, over 5.8 years, 23% of people who did not have diabetic neuropathy, and this is a large NIH study that we did, developed diabetic neuropathy. And again, what we showed is that if you had less nerves to start with, especially a corneal nerve fiber length less than 14, you predicted your ability to develop, or not you predicted those who develop diabetic neuropathy, clinical diabetic neuropathy. So is there anything we can do for diabetic neuropathy, or do we just diagnose it and commiserate with the patient? Well, we know that glucose is important, dyslipidemia is important, and inflammation is important. And we know that there are risk factors for diabetic neuropathy. This is a study published in the New England Journal of Medicine in type 1 diabetes. And what it shows you is for diabetic neuropathy developing, you can see many of the conventional cardiovascular risk factors, blood pressure, smoking, HbA1c, diabetes duration, being more overweight, having higher triglycerides, all of them predict diabetic neuropathy. And in fact, in the Gulf region, we've looked at this and we've shown exactly the same. In type 2 diabetes, if you're older, you're more likely to develop diabetic neuropathy, longer duration of diabetes, poorer glycemic control, hyperlipidemia, hypertension, obesity, less physical activity. All of these factors predict people who develop diabetic neuropathy. So, does treating these risk factors improve diabetic neuropathy? Does treating blood pressure? Well, we actually, again, did the study. This is before I discovered corneal confocal microscopy. I only wish I had it then. This is 20 years ago, where we took people who were normotensive, no microalbuminuria, and we gave them an ACE inhibitor, trandolapril, and we measured their nerve conduction. And what we showed is that there is an improvement over 12 months in nerve conduction, M-wave amplitude, and F-wave latency. So treating with an ACE inhibitor can improve neuropathy. And subsequently, in an Italian study of patients with type 2 diabetes, 380 with microalbuminuria, treated with an ACE inhibitor or a calcium channel blocker, or both, they were able to show neuropathy development and regression. So that both development diabetic neuropathy was reduced if you were on either a combination of namidipine and an ACE inhibitor, or delapril alone. You could reduce the development of neuropathy, new onset of neuropathy, and also people who already had neuropathy actually showed an improvement. So suggesting that these agents that we use in blood pressure have an impact on neuropathy. The other things, of course, is HbA1c. Well, in type 1 diabetes, we know from the DCCT, using neurophysiology, that there is an improvement in neuropathy. But in type 2 diabetes, actually, it's not quite the same. If you look, most of these studies have not shown an improvement in diabetic neuropathy. And of course, people say, well, in type 1 diabetes, patients were younger, had a shorter duration of diabetes, earlier diabetic neuropathy, and that's why they improved. Whereas, and they also use nerve conduction. Whereas in the type 2 diabetic patients, you can see they were older, had a longer duration of diabetes, more advanced DPN, and that's why they didn't improve. But one of the key reasons, I think, is they didn't show an improvement is because they used the wrong tests. So they used neurological exam in most of these big studies, cardiovascular outcome studies, which to me is a waste of time in a clinical trial setting. You need sensitive tests. And in fact, using corneal confocal microscopy, this is in a study where we've taken people with type 1 diabetes undergoing pancreas and kidney transplantation. And we've looked at CCM before and then over a 36-month period. And what we show is corneal nerves start to repair within 6 months. This is people who have got end-stage neuropathy almost, because they need a new kidney because they have end-stage renal failure. And yet, we are already showing that there's an improvement in corneal nerves. Skin biopsy, not very much. Interestingly, symptoms and nerve conductions didn't improve for about 36 months. So using these tests in a clinical trial is a waste of time, because really, if you're doing a 12-month or a 18-month trial, you will see no change. The other thing that we've done...
Sorry, 2 minutes.
Okay. GLP-1. So we know that in the LEADER trial, liraglutide showed actually there was less amputations if you were on liraglutide as opposed to if you weren't. And in Qatar, actually, with Mohammed Abdul Ghani, we actually did a study where we looked at once weekly exenatide with basal bolus insulin, and we were able to show, using corneal confocal microscopy, if you can beautifully improve the glycemic control, but you also see an improvement in nerve fibers. So there is corneal nerve regeneration, both with basal bolus insulin and with GLP-1 therapy. BMI, well, physical activity. We've actually, in Qatar, done a study where we've looked at people who are sedentary and people who are active. 30 minutes of walking more than 3 times a week. And we've used corneal confocal microscopy over 2 years. And what we've shown is that if you are physically active, that's the blue, the nerve fibers start to repair. If you are not physically active, then your nerve fibers degenerate. So that's important, that we should be doing physical activity. Okay, and finally, for the effect of triglyceride lowering, this is a trial published in Diabetes about a year ago, looking at omega-3 in neuropathy. They used a whole bunch of measures: median nerve excitability, sural nerve conduction, tibial nerve conduction, perineal nerve conduction, QSART, quality of life, MNSI, before and after intervention. Guess what? Did they improve? Thank you, Mohammed. Nothing improved. But guess what did improve? Anybody? CCM. Corneal nerves started to repair within 180 days of therapy with omega-3. And finally, fenofibrate. We know fenofibrate, this is for the vascular surgeons. We know it's an amazing sub-study actually. Field study showed that in a cardiovascular outcome trial that failed, if you gave fenofibrate, you reduced minor amputation by 50%. And yet, we hardly use fenofibrate. And just published this last week actually, in diabetes is a study of 30 patients with type 2 diabetes treated with fenofibrate for 30 days. They had an improvement in triglycerides, but look what else improved, corneal nerves. So you have, within 30 days, you're seeing repair of nerve fibers. So in a clinical trial setting, to me, that has to be the primary endpoint. Finally, I'll just finish. I know, but I have to show you this because this is so beautiful that how Qatar have managed to do this FIFA World Cup. So, you know, you've heard of Mbappe and Messi and everything else. Let me just show you somebody else. This is just to show you that I'm not old and past it. Okay? Just look at that Thank you.
Thank you, Dr. Malik.
This was last week.
Because we started a little bit later today, we have the opportunity to have two questions, one for Rami and one for Malik. If anyone have one question for Dr. Malik and one for Rami Salame.
Take people with IGT who have pre-diabetes who have reduced confocal nerve fibers, and we treat them. Would we restore that back to normal?
I need you to come back to Qatar and we do that study, inshallah.
حكينا one question, Haytham. Okay, Dr. Haytham.
Microscopy or whatever, it looks an expensive instrument, and I don't know how we can in practice widespread it.
Yeah. So it's actually around $60,000, but once you have it, you can use it as many times as you want. And that's the key. And an EMG machine is costing around $30,000. So it's not really that much more. And it's actually in good ophthalmology offices, it should be there. Yeah. Yeah, and I'm working on, I mean, I'm not going to make any money out of it, but I think there's a need to push the technology to make it cheaper. And at the moment, Heidelberg are the kind of the only players who are making this instrument. I think we need to make a new instrument to push the price down.
Any question to Dr. Rami Salame? Rami Salame. Okay, تفضل.
Thank you. Actually, I want to know about metformin during pregnancy again, because recently there is some studies that metformin can do some congenital anomaly in neurology in the fetus. Really, it is safe to use metformin during pregnancy?
That's a very good question. As I answered during the slideshow, essentially it's a very controversial point. Don't forget that metformin is one of the very commonly used medications. It's been around for literally 100 years. Probably most of the endocrinologists in the room have used it in pregnancy. I'm not personally aware of any, and I'm not sure like the strength of the study that you're talking about, like what did it exactly show? I'm not aware of that study. But what I do tell you is I partially agree with you that we cannot guarantee its safety necessarily, and that's why the ADA most recent conference said that it should not be used as a first line in gestational diabetes.
Thank you.